Sales Director with SeniorLivingGuide.com. I also host our Senior and Caregiver Resource Podcast, SeniorLivingGuide.com podcast, which can be found anywhere you listen to music or podcasts. And we are in season 4 and just completed our 74th episode. And actually, we have one with Dr. Kliansky in a podcast as well, which is pretty mind-blowing. So you might have to check that out as well. We also have 4 print publications in the US. We have Florida, North Carolina, South Carolina, and Virginia. And then, as I mentioned, we also have our hospital directories, which are nationwide. I think there are over 40 markets at this point. So that's really where we work with our clients. And then also, clearly, we have the national reach website, SeniorLivingGuide.com, and that really just connects all of our online users with the communities and the home health care and resources that best fits their needs. So that's what we do. And I'm going to go ahead and turn it over to Dr. Kliansky, and he can share a little bit about himself, and we'll get started.
Great. Thank you so much, Darlene. As you pointed out, we did a podcast a little while back. It was one of the best podcasts I've done, and I was thoroughly entranced by you and everything that you brought to it. So I see that this is a great audience and a great venue for talking about this topic.
Yeah.
We're here today to talk about dementia prevention, which is a passion of ours, mine being my wife, Emily Kliansky, a physician. She's both an internal medicine doctor and a psychiatrist/neurologist. I am a board-certified clinical neuropsychologist, which is always a little bit of a big word for people that stops them from asking me what I think about their dreams when I meet them at parties. They just say, "Oh, that's interesting, neuropsychologist." Basically, what we do as neuropsychologists is we measure how people think. So we look at how well they pay attention, how well they learn, how well they remember new information. We look at their problem-solving skills. We take all that information and we use it to make diagnoses, especially diagnoses related to, what someone's thinking is normal for their age and background, or whether it's abnormal. And if it's abnormal, what could be causing it? And even more importantly, what can we do about it? And we've been doing this for a very long time. I've been practicing for 45 years. And during that time, I've seen about 30,000 people for evaluations. So a lot of time of talking with people about their thinking and looking at their memory. What we are doing with this whole dementia prevention is taking the kind of things that we used initially for treatment and finding that we're doing so well at helping to prevent decline that we started using it earlier and earlier in the process, and then discovered that there is really quite a bit that can be done. In fact, we can cut our dementia risk by 50%. 1 out of 2 cases of dementia are preventable. So that's what I'm excited to talk about with you and your audience today.
Yeah, absolutely. I'm excited as well, because as you know, my father passed away from dementia. And, when you have a family member that has dementia, you start questioning when you walk into a room, is it starting to affect me as well? It can be very scary because it does seem to be hereditary.
Well, let me go through our model and talk about it. It's got a lot to cover. It's telling somebody I feel sort of like trying to squeeze myself into a pair of jeans Monday morning after eating too much pizza and beer over the weekend and saying, okay, I got a lot of slides to squeeze into this time. So let me plunge into this.
Okay.
See how this, it's got to find my, there we go. Okay, this is my overview. We're going to talk about dementia as a progressive neurological disease that has some very important implications, talk about the various forms. The treatments that are currently available are not really cutting it as far as we're concerned, but prevention is a very good way of going about this, because if you could fix it before it starts getting broken, you have a lot more success down the road. We want to do everything we can to help people be the one in the 1 and 2 equation of who can prevent dementia. And then we're going to try to individualize this and talk about what people's individual risk factors might be and how they can discover this, but also to determine how we can apply this in a senior living environment where I think there are lots of opportunities. So let me move on ahead with this. What is dementia? It's always the big question. People keep trying to figure out what exactly this disorder is. It is a progressive disorder. It gets worse over time. It's not normal. It's different than the, oh, I walked in this room. Where did I leave my coffee cup? Or what was that word I was trying to say in that conversation a little while ago? It involves more changes in things like memory, attention, what we call executive functions, planning, decision-making, organization, and it can interfere with the ability to speak and to understand speech. It's not just cognition, though. It also impacts how we feel. Anxiety, apathy is a big problem in many cases early in the course and even later in the course of dementia, where people who used to be hard driving and organized don't want to do things. Irritability is also a common feature. And later in the disease course, as many of your audience knows, it can turn into agitation and hallucinations and even delusions where people believe things that are not real. It also impacts a lot of everyday activities for people still living in the community, how they spend their money, what do they fall for in terms of scams, how they organize themselves to carry out their activities, whether they can pay their bills on time, and later on, whether they can even bathe or dress themselves. So really, it's the brain. So it controls everything that goes on in our bodies, and we have to do whatever we can to keep our brains working well throughout the course of our lives. That's what dementia prevention really is about. We know that the course of dementia is progressive. If you see on this slide, there's the blue line, which shows what normal cognitive aging looks like on tests that we administer. As we get older across the bottom, we find that everyone loses a half a step. Everyone loses a couple miles per hour off their fastball, as we say in sports. But still, they're able to do the things that they usually can do. It may take them a little bit longer, but they can still do them. Some people have a departure from that, and they move into a phase called mild cognitive impairment. Now, this is a precursor to dementia. So if you see that star there, that's sort of the point where I'm arbitrarily saying that's where we turn the corner. Mild cognitive impairment becomes this more rapidly progressive disorder. What we know is if we can find people at mild cognitive impairment and use that as a wake-up call to figure out what's going on, we have a much better chance of preventing their decline later on. But it's even better to catch them early, back in this blue line, before there is any decline that's abnormal, because then we have a much better chance of helping people to stay on that positive line. Dementia is not just one disease. One of the most common questions people ask is it Alzheimer's disease or is it dementia? And the answer is oftentimes, but yes, it's both. Alzheimer's disease is a major form of dementia. There's debate as to whether it is the primary form or not, because there are a lot of vascular dementia cases. And what I couldn't show in this particular pie graph was that a lot of the cases, in fact, the most common form of dementia is a combination of vascular factors having to do with circulation, blood supply getting to the brain, as well as Alzheimer's disease, which is characterized by changes within the brain involving the buildup of a thing called beta amyloid, which is a protein that builds up and forms plaques in the brain, as well as the buildup of another protein called tau, which causes a breakdown in the nerve fibers, so that true Alzheimer's is associated with two changes that we see in the brain. But for many people, there are microvascular changes, things that deal with the connectivity under our brain surface. Parkinson's disease is also associated with dementia. About a third of the people with Parkinson's disease do develop memory disorders. We have frontotemporal dementias, FTD. That's what Bruce Willis has. It has two variants, both a behavioral variant, where a person doesn't have much memory change, but they have a lot of change in their activities and their abilities. And they also have a speech variant, a verbal variant for that, where there's a lot of aphasia or difficulty finding words. CTE, which is repetitive head trauma, chronic traumatic encephalopathy, and other types which make up the remaining 5%. Now, people will differ in terms of exactly what the percentages are, but take it from me, it involves a lot of different things. And so we're not dealing with just Alzheimer's, we're dealing with all-cause dementia. We know that there is an increase over time as people age and stay healthy to longer lifespans. And this was a model originally developed back 30 years ago, but it's still largely true. What I've done with this model is turned it into two different types of dementia, the Alzheimer's form and those other dementias, which are in the orange. And what we see is there is an increase that's going to be very significant in the next 10 to 20 years. It's already pretty bad, but it's going to only increase as more and more people age. Consequently, we need to put into action a different plan, one that takes the current levels of dementia that we might see 6 years from now in 2030 and levels those off. Because if we don't do something about this, there's going to be so many people with dementia that the strain on our finances and the strain on caregiving bodies is going to make it very difficult for us to have a good outcome. We have some current approaches to treating dementia. We have had oral and also transdermal medications that are delivering their medication by form of like a Band-Aid type of patch since the late 1990s. These are from a family of medications that have to deal with a chemical called acetylcholinesterase. The one that most people know about used to be called Aricept. It's now called donepezil. There's two others from that same class of medication. We also know that there is another class of medication also approved late in the 1990s, used to be called Namenda, now called memantine. These are actually more effective at helping to stop the progression of this condition than people give them credit for. The problem is most people say, well, it doesn't make them better, so what good is it? Well, in the field of dementia, treating things and stopping them from getting worse is really important. The new areas involve things that are particular to Alzheimer's disease. These are from a family called monoclonal antibody medications, or MABs, and those are the new infusions and possibly some pill forms. I'm not going to spend time on that. It's a whole lecture by itself. And the other area where we're spending a lot of time and money is on support for patients and caregivers, which is really, really important, as your audience well knows. But the good news is that 1 in 2 cases of dementia can be prevented. We started really looking at this research in a combined way back in 2017 with a Blue Ribbon Commission in the United Kingdom called the Lancet Commission. And they identified 9 factors which could help to prevent dementia. 3 years later, they added 3 more factors for a total of 12, and they estimated that 40% of all dementias were preventable. That was great news, but a couple years later, these same 12 Lancet factors were applied to the United States Health and Retirement Study, and in this group of some 2,000 individuals, the authors found that actually 62% of all dementias were preventable. So we have taken the 40 and the 62, split the difference, and come to the saying, because it's easier for people to remember, that 1 in 2 cases can be prevented. Now, when Emily and I looked at the research and developed the model, which I'm going to show you, we actually identified 8 additional factors. So we are even more confident that we can reduce significantly the likelihood of any individual having dementia. So let me talk about this model and build it step by step. Those of you who have chanced upon our book, Dementia Prevention: Using Your Head to Save Your Brain, will see this model built step by step through 10 different chapters. I'm going to give you the quick version of this model today so you can see how this is developed. First thing you need to know is it doesn't come from one area. I think the one question that I'm asked the most is, what's the one thing we can do to reduce our risk of dementia? And I tell people, it's not one thing. And in fact, it comes from a number of areas of study, medical areas involving neurology and psychiatry, but also internal medicine, basic good medical practice, cardiology, breathing problems, both pulmonology and sleep medicine, endocrinology, because we're going to talk about diabetes. There's a lot of really recent things showing that the environment, especially the air we breathe as children, can have a later effect on our dementia risk.
Mm.
Obesity, which is a growing epidemic, is also associated both directly and indirectly with dementia. And we get into looking at some of the interventions through exercise physiology. But we're going to start with genetics because that's what most people are interested in, is how has this hand been dealt to me from this deck of various genes, and does that change my risk? So let me start there and tell you that this is the model. It's a little overwhelming, and that's because we got to break it down into steps, and that's what we're going to do, and you're going to see how this whole thing comes to pass. We start with, what's your dementia risk? That's the basic question. What's in the middle of this diagram? And we talk about things like our genes, things that happen to us stressfully early in our life, particularly abuse, and what happens before we're even born, our prenatal environment and the things going on in our childhood. We add to this the effects of education and trauma. So let me blow this up a little bit so we can talk about those. Genes do exert some effect for some people. There's a few small groups of people where genes are a major effect, and those are usually very early onset genetic loadings. So people know about this oftentimes in their 50s because their parents' generation is replete with people with dementia. For most of us, however, it simply adds or subtracts from our overall risk. It does not determine whether or not we get this disorder. Early life stress, that certainly impacts how our brain develops from a very early base. In addition to that, if our mother drank alcohol during pregnancy, smoked cigarettes during pregnancy, did drugs during pregnancy, we're starting off life a step behind the pack. Things we have some control over early on is staying in school longer, going back to school, getting more education, because it turns out that those with higher educations can withstand some of the other stresses to a better degree before losing cognitive ability. We also know that there's traumas that occur during adolescence where people are more likely to take risks, where they have head injuries or play sports that cause repetitive injuries, which can later on come to be a problem. For most of the people I talk to, these are in their rearview mirror. They're coming to me in their 40s or later. So now we're looking back at this model on the right side here, starting to look at those midlife and oftentimes cardiovascular factors. Hypertension and type 2 diabetes, both of which in many cases are fueled by obesity. Adding to this, other risk factors involving tobacco smoking, loss of activity, sedentary lifestyle, and diet. Now, I will tell you that when we look at these kind of factors, most of the books that are written on this don't talk about sedentary lifestyle. They don't talk about smoking. They talk about diet, eating our way into better cognitive health. Maybe we should open a string of dementia prevention restaurants, just serve a Mediterranean diet and we'd fix this problem. There's a problem with this factor, which is that doesn't do it. While eating a very good Mediterranean or mind type of diet is much better than eating a terrible diet, there's literally not much difference between the mind diet and a good, varied, healthy diet. So please don't get stuck on how many berries you're eating or exactly how you're dieting. It's really a question of weight. How much stress are you putting on your body by being overweight? And what does that do to your blood pressure? And whether you're smoking, because that will impact your blood pressure and also make it more likely that you're going to not want to exercise. Exercise will offset some of these other problems. It'll certainly help with weight control. It'll help with diabetes management, and ultimately it'll help with hypertension. We also make a lot of decisions based on whether or not somebody is taking the medication that they're prescribed. Because hypertension, high blood pressure, is a silent kind of disease, we see a lot of people who just don't think about it, and so they skip their medications. Very dangerous kind of thing to do. They don't appreciate the fact that this is causing a problem then, but it's the wear and tear on their blood vessels going up to their brain as well as to their heart that causes problems with their general health, but also puts them at increased risk for dementia. Type 2 diabetes is really important that people treat this. I know there's a lot of new medications that are out to try to reduce weight as a form of treating type 2 diabetes. So all those GLP-1 medications, those injectables, are going to be really important for the future of dementia prevention. If we go down to the bottom, we see an area that most people don't pay much attention to, but we consider it the secret sauce in this formula: oxygen. Because oxygen plays a pivotal role in our brain's ability to deal with the factors of making molecules for energy, as well as clearing out through our lymphatic system, which operates only while we're sleeping, the toxins that build up in our brains during the day. You have to get oxygen to your brain for these systems to work well. If you have chronic obstructive pulmonary disease, hypoxia, where your oxygen levels are low and you're not taking oxygen at night while you're sleeping, you could be interfering with those processes. If you've got obstructive sleep apnea, in which case you stop breathing, or your level of oxygen in your lungs decreases by 4% or more, and you're doing this 5 times an hour, so you're simply not breathing enough while you're asleep, you can have a condition called obstructive sleep apnea. That'll interfere with the oxygen, so it causes hypoxia. It'll also interfere with your sleep continuity, because you'll be tossing and turning and waking up multiple times. You'll also be going to the bathroom multiple times, because interestingly enough, it's also related to whether or not we have nocturia, periods of going to the bathroom and peeing during the night. So identifying and treating sleep apnea is a really important thing. Turns out it's a much more common condition than we ever thought. In the last 3 to 4 months, there was a study published that looked at 7 different centers across the country that do routine screening of people for a variety of medical conditions. The Framingham Heart Study is probably the most famous of these different centers. They took a look at 6,000 people who came in to be followed every 3 to 5 years and have a variety of tests run on them. Now, these are not clinical patients. These are people from the general population. They gave them each a one-night sleep study in their own beds, painless study. 6,000 people over the age of 58. Half of them had undiagnosed sleep apnea. So this is a really important kind of condition. If we can diagnose it, if we can treat it, we get much better outcomes and a better chance of avoiding dementia as we age. So if your partner is snoring and up and go to the bathroom multiple times per night and sleeps restlessly and falls asleep watching TV, good chance that you should get that person a sleep apnea test. Over on the upper left-hand corner here, we're going to talk about some factors in our bloodstream that should be tested to look at, first of all, our vitamin B12 levels, which typically are already tested by doctors, but they usually don't test for homocysteine and then methylmalonic acid. If those are elevated, they can get in the way of the vitamin B12 being used by your brain. Folic acid and iron are also important factors. Those are actually two different things. They just look like they're the same, but they're folic acid on one side and iron on the other, and vitamin D levels. We talk about more specifics in the book. I'm not going to go over these in any great depth, but there are some blood tests that we talk about in our questionnaire that should be looked at. We then look at what you're taking in terms of drugs that are prescribed and in some cases drugs that are not prescribed over here on the left, as well as the effects of alcohol. So let me focus in on these a little bit. There's a class of drugs called anticholinergic drugs. These drugs typically as a side effect lower the levels of acetylcholine in our brain. The medications we currently have and have used for years to help prevent decline in dementia are all aimed at trying to keep our cholinergic levels up. They are procholinergic, and yet many of the people we see are on multiple anticholinergic drugs. Some are prescribed. There's some heart medications that are very important. They just happen to be anticholinergic. There's some antidepressants, same thing. There's also drugs that people take to tighten up their bladder so that they don't experience periods of overactive bladder that wake them up in the middle of the night. Well, it turns out these are also anticholinergic, and one of their side effects is they can deplete the level of acetylcholine in our brains. We also see these in many of the common sleep medications. So those things with the PM at the ends of the name, the Tylenols, those other PM medications contain diphenhydramine, otherwise known as Benadryl, which is anticholinergic. Then you have the medicines you take for a cold, the medications you take for allergies. And what happens is you can be on 3 or 4 of these without even realizing it. And we're not sure whether this actually increases your risk of dementia, but it certainly can make you feel unable to think clearly and to have everyday medical memory problems that can be improved if you change your level of medications. Well, there's linked to our book an anticholinergic burden calculator that allows you to put in each of the medications, whether it's prescribed or not prescribed, and that will tell you how anticholinergic is that drug. And you can figure out for yourself and go have a discussion with your doctor and perhaps cut back on some of those things that you're buying over the counter. These two at the bottom here, the benzodiazepines, the anti-anxiety drugs, the lorazepams, the Xanaxes, the Valiums, the Libriums, the medications that are used and designed for temporary relief of anxiety can cause problems and actually lead to dementia if they're taken consistently for long periods of time. So taking a look at that, but don't go off of those on your own, is the advice we always give people. In fact, none of this should be taken as medical advice. These are things to talk about, to explore, and to talk about with your doctor. We don't want you just stopping the Valium that you've been taking every day for the past year because you can have a reaction to that. Opioids can also get in the way of thinking and can be causes for decline in our cognition. Alcohol, probably the most accessible thing in this whole diagram that people can do that can cause problems if they do too much of it. We're always asked the question, how much alcohol is okay? How much is too much? So taking a careful history is really important in figuring this out. Also taking a look at when someone says, I only have a drink or two, whether they're actually having a drink or two, or whether they're really pouring a lot more than just a drink or two, can be very informative to making decisions about what's healthy for you. So taking a look at that, and one of the problems we have when people retire is they have a lot more time on their hands, and 5 o'clock comes a lot earlier for some of them than it should. We then look at this last group down here, and I realize again, this is a lot of information, and we could spend 3 hours talking about these specifics. But again, these are all in the book as well as on a bunch of podcasts. I ask people to take a look at this because the more informed we are, the better we make decisions. We get down to a lot of the social things here. Isolation, loss of cognitive activity, depression, which is both a cause and an effect from social isolation, and also sensory loss, especially what people don't recognize is the effects of hearing decline. We don't typically lose hearing all in one day. It happens gradually. And we generally will assume that other people are mumbling. We're turning up our TV just a little more, until eventually someone says, "Why is that so loud?" And you didn't realize you were turning it up very much. Turns out that hearing loss is one of those reversible or treatable forms of dementia prevention that does play a role. So I send a lot of people off for hearing tests in my practice, and we recommend that people, if in doubt, check it out. Social isolation is so important because we are social animals. People are meant to exist in groups, and the lack of connectivity, whether through having lost people through death or geographic displacement. Can't tell you the number of people here in the Northeast say to me that the winter is bad. Not only is there not enough light, but all my friends are in Florida. So they have social isolation from a couple different directions. And when people retire, unfortunately, sometimes they retire from life. They don't spend much time doing things that are cognitively stimulating. They don't recharge their brain, and they don't grow new connections. So it's very important to get people to do things and to think. But it's easier said than done. I realize that. So here's the whole model put together. So you ask the question, what's the one thing I can do? Obviously, there isn't. It's a lot of things. And here's what makes it even crazier. These are, in many cases, interconnected. So it's not just the fact that sleep apnea, for example, down here in the bottom is a dementia risk, but it's also a cause of high blood pressure, which is a cause for dementia risk. It's also, in many cases, aggravated by excessive alcohol use because alcohol reduces our respiration while we're sleeping. It's related to hypoxia, as we talked about, but that's also a sedentary lifestyle factor. So we have all of these things. It works together in what I call the Gordian knot. Those people who remember their history, remember that Alexander the Great found himself at a point where he was trying to take over the world, and he encountered this knot that had apparently by its design been impenetrable to anyone being able to untie it. And his solution to this, to be able to rally his troops to go on and conquer the world, was to take out his sword and cut the Gordian knot straight through. Unfortunately, we can't do that with dementia and this Gordian knot. What do we have to do? We have to untangle it, one strand at a time. In order to do that, it's really helpful to figure out where your strengths and weaknesses are. Everyone's got a different knot. So it's not one size fits all approaches to this. Instead, it's a matter of taking a quiz, figuring out where your strengths and weaknesses are. We've put together a checklist for this very purpose. It's a free checklist. You can either do it online. If you hold your phone up, you can get the QR code, or you can go up to braindoc.com, which is our website, and for free, take this quiz. You can download it as a PDF and fill it out at your leisure. There's some things in there, especially some blood tests that you probably don't know the answers to, that you're going to be able to get your doctor involved with. What we're really excited about is we're working now on a model of taking our dementia prevention model and personalizing, individualizing, making this available so people can get their own individual type of dementia prevention guide, a playbook where they can see, for example, this is somebody with pretty significant cardiovascular problems because all those red areas have to do with circulation. They're also drinking too much. They don't do enough with other people. But yet they're not taking anticholinergic drugs. They're not taking the benzodiazepines. Their hearing and their vision's pretty good. By taking this questionnaire sometime in the next month, we're going to have it set up. So if people choose to do this, they'll be able to get a whole guide for themselves, a report of their dementia prevention risk and their plan. So the question then, we'll get back to the beginning, how to reduce dementia risk for individuals and for groups. From an individual point of view, you have to generate an action plan. That's what we were just talking about there. Find out what your program needs to be. Find out what your risks are. Recognize that change is important throughout our lifespan. We can't be perfect. We're still a work in progress. Change is just as important in the third section of our life from ages 60 on as it was in the first couple groups of our life or sections of our life. It's important to then make changes, to have actionable goals, to break down general ideas like I'd like to exercise more into really specific interventions and being able to hold ourselves responsible so that we can stick with those kinds of things. In this case, we've broken down the get more exercise into taking a brisk walk for 10 minutes 3 times a day. Actually, a very effective program for getting sedentary people off their butts and out the door. Focus on the process. Where will I do this? How will I do this? So that I actually even have a backup plan if my first plan is interrupted by weather or other circumstance. We make this a priority in our lives. And then when we screw up, which I guarantee you, you like everyone else will do, you treat it like the modem on your cable. You unplug it, wait, restart the program. So translating things like this into actionable steps is really important to change your risk. That's how it's done. It's not just by knowing, it's by acting. When we start to look for community interventions, what can we do in senior living? What can we do where people are together? Number one, we can make dementia prevention a priority. Develop your program into an active dementia prevention program. Select residents if you can, if it's not that competitive that you take whoever happens to get in there, but try to select residents who are motivated. I tell you, if you set up the program and says, this is what we do, you're going to attract people who are interested in doing it. Then work on your programs. Focus on activities that give you multiple benefits. One of the recent papers that was written in the journals has to do with group exercise, including some competitive activities, actually being more effective in keeping people exercising longer and more effectively because there's a social element and somewhat of a competition. So look at group exercise. Look at group problem solving. How can you keep your people active still in the community and engaged rather than withdrawn? How can you highlight the talents of your residents and encourage them to be able to bring them to this community? How can you bring in outside people and events so that your environment is enriched? Because the more interesting things that are going on, the more people show up, the more they learn and do. How to make your community an exciting place to be. You also want to encourage those reluctant residents and help them to overcome their resistance. It's a problem I see all the time with people who are in independent living and traditional assisted living, where they are not pulled out of their rooms for meals or other activities. And there's not enough of an emphasis, in my opinion, on helping people to do that so that they actually take advantage of everything that's going on. And find ambassadors within your community who will improve the social goals and help reluctant people to get involved. Sometimes what it really takes is someone else saying, I really miss seeing you. I'd like you to be with us and be involved in this. Anyway, here's our takeaway messages. They're the first things we looked at. It's a progressive neurological condition. There's many forms of this. Treatment and care are costly and usually come on the scene too late. Prevention is a goal that can reduce the cases by 1 out of 2. You want to do everything possible to be a 1 and not a 2. You can do this by discovering your risk factors and then making changes so you can improve everything that you can. So, questions?
Questions. We do have a few in here. If you have questions and you haven't put them in, please feel free to do so at this time. I'm utilizing the chat box just because that's easier for me than toggling back and forth. So I'm trying to keep it. So I saw a couple right in here.
I'm going to stop sharing here.
Oh, okie doke. Hold on. Okay, where it is. Okay. Let's see here. You switched it. It threw me off.
I'm sorry.
No, you're fine. I just got to go back and find it now. So Glenda asked, and I'll just reiterate, we will be emailing the recording tomorrow. So then I am a 64-year-old and my mom's family, all her brothers and sisters suffered with Alzheimer's. Now my concern is I look like my mom, talk like my mom. I'm trying to see the rest because I just
don't want to think like your mom, I think is what the next part is.
Yeah. I'm so keen to Alzheimer's, far, far away, but your input would be greatly appreciated. So.
Yeah, I think it's the same thing. I tell the story, but years ago I read this book called I'm Dancing as Fast as I Can. The prelude to the book is a joke. It talks about this couple that meets at a resort and they are dancing with each other. And the guy says to the girl, listen, I'm only going to be here for the weekend. She looks at him and says, I'm dancing as fast as I can. How much can you do?
Right.
No matter what your risk is, you got more concerns because you got family members where there's a strong history.
Right.
Okay, that should be even as motivating or more motivating to say, where are my risk factors? What can I improve? We know that there are things that we can do even if you have a diagnosis of dementia. And one of the things that Emily showed in her research, which I co-authored with her, which we presented back in 2014 at the American Academy of Neurology, is that if you apply this dementia prevention model to people already experiencing cognitive decline, you add to that the medications which we've had out since the 1990s. A good number of these people get somewhat better and stay better for the next several years. So even if you have a diagnosis or your family member has a diagnosis, things are not entirely out of the future probability. You can still do a lot, especially if you also add medication to the mix.
Right. So I think it's more of a comment, but I'll read it anyway. My mother was having some questionable comments, but was otherwise living independently in October of 2023. Within days, she went from that status to being totally dependent for her care. What would cause such a sudden, I've seen this myself. My dad did the exact same thing.
Well, first thing is you need to go to a physician, get a really thorough workup. There's a number of things that can cause big change. I mean, the first thing, whenever you see somebody who has that rapid a change, you have to look for infections.
True.
because
Yeah.
that can really make a
UTIs
difference.
typically. Yeah.
UTIs or viral infections, because, by the way, anyone who is having any questions about should I get vaccinated for transmissible diseases, I don't care whether it's the COVID vaccine or the RSV vaccine or vaccines for the flu, the answer, in my opinion, is yes. Because if you are having cognitive weaknesses, a viral infection, or on the other hand, a fall, which could also cause a fracture, can be the trigger for a downhill kind of process.
Mhm.
Same way with potentially voluntary or non-essential surgeries. So you want to take a look at all of those factors, because it's a straw that breaks the camel's back phenomenon in some cases.
Right. Right.
So
Oh,
I would
for
go
sure.
to the doctor immediately and say, okay, this is a major change in
Right.
this person's functioning. Let's run all the tests, turn over all the stones.
Well, so, and this is my question to you, just kind of piggybacking on that, is that I do feel like if you have someone that is experiencing extraordinary amount of stress and life change, I think that just catapults it. It can really make it significantly worse. And then there's my dog. So, um, curse that Amazon delivery guy, because I guarantee that's what it is. So one of the questions was ashwagandha, will that help? And if yes, what dosage needs to be taken?
As far as we know, there are no true double-blind, placebo-controlled studies that show that any supplements that you take, any vitamins that you take, unless you're deficient in that vitamin, any vegetables ground up and stuck into little capsules, or fruits ground up and stuck into little capsules, or any jellyfish proteins are going to do anything of real value. So save your money. If you have a vitamin deficiency, talk to your doctor about how to replace that. But the stuff that you see advertised on television, not worth the dollars that you're spending.
Exactly. And I know I've had a conversation with some doctors about vitamins and the over counter, and it's not as cut and dry as it seems.
There's a lot of people who typically what we see is there are things that are in these capsules that by themselves are helpful, or at least in animal models have been found to be helpful. There's a big step between animal models and people, number one. Number two, there's no FDA regulation of what actually is in many of these, because they're not regulated by the FDA, so we don't know how much there is. Then the question is, how much of what you're taking actually gets through your digestive system into your bloodstream? And then, assuming that it gets into your bloodstream, how much of it's getting across the blood-brain barrier into your brain? And the answer is not very much usually, and not in a reliable format. And if they come out with some studies that are replicated, that are well designed, that shows that there's an advantage here, I'd be all for it. But they just don't exist right now. I'd like to keep the future open, but right now we're not seeing this at all.
Right, right. Another question was, you mentioned how many drinks were too many without giving a guide. Help.
Yeah, it's always one more than I drink, actually, is too many. The rule generally is, and this is debatable, because what the MRI studies, magnetic resonance imaging studies, tell us is that alcohol does not do good things for anyone's brain. So people who drink have worse looking brains on MRI than people who don't drink. However, in general, the rule we use is that generally one drink for women and 1 to 2 drinks for men. And we don't want you binge drinking, because that's bad for everybody. But the question becomes, what's a drink? And here's the rule. 3 to 4 ounces of wine is a drink, not the pour that you get in many restaurants or that you might pour at home. 12 to 16 ounces of beer, traditional 4 to 5% alcohol beer, is a drink, not the craft brews, which are 8 to 10%. That's 2 drinks. 1 shot of distilled spirits, vodka, rum, bourbon, doesn't really matter. So question I ask people is, do you measure it or do you pour like your neuropsychologist pours? And they always get the joke because it's really
Yeah,
easy to pour. I say, I'm just having one drink. I've
right.
had people already say, well, it's just one drink. I say, how do you pour it? Well, I fill it up about halfway with vodka, then the other half with seltzer.
I
So
think
well,
of
that's
Johnny
probably
Depp
three
and
drinks.
I think of Johnny Depp and his mega pint. That's one drink.
Yeah, there's a lot of, I mean, it's a very social kind of thing. It's a hard thing for many people, but in general, I mean, again, it depends on what else is going on with your dementia risk and how
Right.
many things you can make a change in.
Right. So one of the questions, and I'm not shocked that this has come up because it's so on topic for this day and age, is what about THC and CBD?
Okay, CBD, probably no problem. THC, there may be a problem. For one thing, when we look at THC percentages, one of the first questions you have to ask someone is, and I do, is what's the percent of THC in this gummy or in this bud that you're drinking, that you're smoking? And oftentimes it's 18 to 30% THC. And these are very often people middle-aged or older who are consuming this. And they used to, in a lot of cases, smoke the available weed back in the day. So if you take somebody who back in the 70s was getting high on 4% marijuana, 4% THC, and they had a 20-year-old brain, and now you have somebody with a 70-year-old brain using 18 to 30% THC, the math is not so good.
Mhm.
Unfortunately, we're probably not going to know long-term effects for some time. We do know in the short term, it reduces speed of processing, it reduces short-term memory, it reduces our ability to think clearly. So when I see someone coming in to see me for testing, if they've had something to smoke or ingest that day, I send them home. If they're using all the time, I ask them, what do you want to do here? Do you want to get a sense of how your cognition is on marijuana or off marijuana? And for a lot of people, I say, do the experiment. You're having some problems finding words. You're having some problems thinking as clearly as you want. Why don't you try not using this for 3 weeks? See what your thinking is like. I think you might find that some of the problems you're experiencing, you might not be experiencing at that point. If you are, if it's the same thing, okay, fine. Then we can talk about what may be an okay enough level for you. I don't really have a problem with people using it once a week socially. I do have a problem with people using it every day for sleep, for pain, or for just getting through the day.
Yeah, the getting through the day part. And then another question, and I don't know what this is referring to, but what about the study from Mass General Brigham and Centrum Silver?
Oh, so there's a study recently that said that daily vitamins a good thing. And
Okay.
the so the study itself, I mean, I don't have anything wrong with taking Centrum Silver or a similar kind of multivitamin, especially if you don't get good nutrients through what you're eating. The effect of taking the vitamin, however, was pretty minimum.
Mhm.
And I was not impressed by it making a big difference. But because it's so inexpensive, because there's a very little downside to it, I don't discourage people at all from taking one. I also don't turn to that as one of the things I'm recommending after someone comes in to consult with me, because there wasn't a large enough change. And I can't remember offhand which test they used that they thought they had a little better result. But from a practical point of view, I thought while statistically significant, it was a pretty minimal in terms of its effect on everyday functioning.
Yeah. So I'm going to run through the last couple questions. I know one is, what's the difference between, oh, tell us again why you feel vaccines make a difference, specifically COVID, and you're just basically saying not to get sick so that it.
Right. So don't, because I see people with long COVID. I know people who have died from COVID, who are my patients' families. But from a dementia point of view, we know that there's an increased risk of cognitive decline when people have any form of infection.
Mhm.
So in general, I mean, there's a couple other preventative things that we don't have in that model right there, but you want to get your dental health in good shape. I tell people that I want them to use the F word. They look at me like, what? I said, the F word is floss, because gingivitis, gum decay, gum diseases can cause changes in cognition, and it's entirely, for most people, preventable. So we're looking at what else we can prevent. So I want people to not get sick in many general ways, because that impacts their brain. And if they're already predisposed and beginning to slip, it can make a big difference.
One question is, if you've been diagnosed with dementia and you've already been seen by a neurologist, I guess, should you continue to be seen by a neurologist?
You should be treated for the dementia. Now, that could be by a neurologist, or it could be by your primary care doctor. A lot of the work I do as a neuropsychologist does not involve neurologists at all. We're working entirely with the PCP, because they can prescribe all of the medications. They can order the sleep study. They can order the blood test. They can order the MRI. I'm not putting down neurologists, but if you're waiting around to see the neurologist, you got to ask the question of what can the neurologist bring to the party? And in some cases, they can bring a lot, especially this woman I saw today who ended up with what we call normal pressure hydrocephalus. She had a buildup of pressure with her brain. Her neurologist looked at her walking and saw that she wasn't walking well, looked at her memory and looked at the fact that she was incontinent and sent her in for an MRI. Turns out she had normal pressure hydrocephalus. She ended up having a shunt put into her brain. She's doing much better now. Those are not the normal, common, everyday cases. Those are the zebras, not the horses. They talk about the expression, if you hear hoof prints, think horses, not zebras. Those are the zebras.
Yeah.
So in some cases, you really want a neurologist, but you want a neurologist that you can see in 6 months.
That's the tough part. I know that
Right.
even just getting the initial diagnosis with the neurologist was like a 3 or 4 month wait pretty much to try to even get in, because it doesn't seem like there's a lot of them, and they're so specialized. It is much more difficult to get in. So this is a very good question, and I actually wanted to ask you the same thing. What are your thoughts on NAD infusions? Because they're growing in popularity.
What kind of infusions?
NAD, NAD. They're somewhat new. I'll send you the information. You can check it out.
What is a NAD?
NAD, NAD. It's supposed to like rejuvenate your cellular makeup, basically. Anti-aging. It's a lot of energy, all kinds of different things that it offers. It can be either an injection or in a drip.
Well, as I'm going to tell you, I'm not too proud to say I don't know.
I'll send you the information. You might want to check it out.
Okay.
It is very new from my understanding.
And you're not talking about MAB injections, monoclonal antibodies.
Okay. MAD. Yeah. I'll send over. Someone said it's a fad. It's a very expensive fad.
There are a lot of fads. Yeah. And there's a lot of money to be made in terms of, anti-aging, rejuvenation kinds of things, because we're all scared of getting older.
Yeah. Oh, 100%. Yeah.
Not everyone's as fortunate as you to look as young as you do. So it's a big issue out there.
Okay. So I had another, so someone called dementia diabetes 3. I had not heard that.
Yeah, I've heard that. And to some extent it is. We know that that not regulating blood sugar properly, especially what they call type 2 diabetes, which is not the kind that's caused by failure of the pancreas early in life, but typically caused by lifestyle, obesity, and lack of exercise and diet. Those all work on the blood supply getting to your brain, the oxygen that the blood's able to carry, as well as to the nerves surrounding your blood vessels. So being able to manage your blood sugars, and people talk about, there's diabetes, which is characterized by a hemoglobin A1C level of 7 or more. Then there's pre-diabetes, which seems to be sort of, well, it's just pre-diabetes. That's a blood sugar level of 6 to 7. But even that increases your risk of dementia by 50%. 7 or more doubles your risk of dementia. So you want to do whatever you can from a medication as well as from a lifestyle perspective to keep your blood sugar levels steady and low, because that's going to allow your red blood cells to carry the oxygen, the nutrients that they need to the very tips of the blood vessels in your brain as well as your heart.
Yeah. Yeah. No, I appreciate that feedback for sure. And that's interesting that it's what it's called. So we do need to wrap it up. We're after the 3 o'clock mark, but I do have a few more comments. First of all, there was a question about where you can locate the SeniorLivingGuide.com podcast. Our podcast is available on our website. And when I send over the information tomorrow, the link will be in there, but it can be found also on Spotify, Apple Podcasts, really anywhere you listen to music. It's under SeniorLivingGuide.com podcast. And we have 74 episodes, so lots of stuff out there. And then how can one get a consultation with you?
Well, they could email me at phd@braindoc.com. I'm licensed in Massachusetts and Connecticut, so it may be that I'm going to give you a generic kind of response, but I welcome emails if people have questions. I'm happy to respond to them and to try to do what I can to hook you up with somebody or to put you in the right direction.
Absolutely. And with that being said, your contact information will also be in the email that they'll get tomorrow with the link to the actual webinar for sharing. So I think that that's all that we have. I really have appreciated my time with you. And I know that probably most of the folks that have joined on, great presentation. I'm seeing a lot of really positive accolades coming in. So we do appreciate that. We appreciate everyone joining us on the educational webinars. It's so important to be informed on these things, not only for yourself, but for the residents in your community as well. So if you have any additional questions, then please feel free to reach out to Dr. Kliansky. I have the hardest time directly, and he can answer those questions for you. But other than that, did you have anything that you wanted to close with?
I just want people to stop being dementia worriers and start being prevention warriors.
Ooh, I like that. I like that. You're going to have to
it's in the book.
Yeah, there you go. There you go. All righty. Thank you everyone for joining us. We hope you enjoy the rest of your day.